Kia ora rā tātou katoa. Ko te arawa te waka, ko Ngāti Whakau e te iwi, ko te parata hoata, te marae, ko Marita Ranclaud hau. Phyllis has already alluded to the fact that I'm currently employed by Lakes DHB. So the rohe of Lakes DHB is right here in Rotorua through to Taupo-Turangi, encompasses Mangakino, doesn't quite go to Taumaranui, and stops short of Te Poke. So we're an interesting kind of a DHB, I think, anyway. Look, this presentation today, I'd hate to think of it actually as a presentation. I think it's more of a discussion that, as a DHB, we've been having with our communities here in Lakes. And the conversation sits against the background of what it is and who it is that we are. I don't know why she said I was a bit of a strategist, but all I know is that innovation in a DHB gets you in trouble. And I just wanted to pick up on some of the kōrero that Patricia was saying in terms of justifying being able to come to a conference like this. I'm accustomed to being the bureaucratic meat in the sandwich. And maybe I can give you some a good rationale for why it is that it's great that you're here today and why it is that you must be here in these places and spaces in future. So, conversation with communities within the DHB. And this conversation sits against a background of Lakes DHB being just a small provincial DHB. We have a total population of just under 100,000 people, so we're not particularly big. And while there are two larger urban centres, so we've got Taupo down in the south and Rotorua right here, on the whole, we're actually quite a geographically spread out population. And often people live in quite rural, sparsely populated communities. There's a couple of other interesting facts about us. We're not a growing population, and in fact, the 2013 census confirmed that we're on the decline, so we're not a growing population group. That's got great things for planners and funders because you can plan around static population groups rather than growing ones. But we are younger than the national average, particularly for our under 19-year-olds, and that's predominantly because of our young Māori men and women. They're breeding, they're continuing to breed. We have a comparatively high number of Māori within our population, so 35% of our population are Māori. The further south you go, the higher that becomes. So when you get down to the likes of Turangi, for example, you're talking about 45% of the population. Compared to the rest of the nation, we have a low Pacific Island population, although they are there. Most significantly for me, particularly when you think about what's playing out in the media at the moment, is that 1/3 of our population lives in quintile 5. So 1/3 of our population lives within the most deprived population groups within our communities. So we're relatively poor. Poverty is absolutely a significant issue for us. And anytime you have those kind of conditions, the needs of your population around health in particular go up significantly. So, just to recap, small population, high needs. And on top of that, we have a significant number of Māori within our population group, and we also have an unenviable suicide rate. So when I think about developing and implementing a suicide prevention and post-action plan, there are some really specific challenges for us. And let's be clear about it. I'll say it again. Suicide prevention and post-vention action plans, it's just not sexy. It's not cool to talk about that kind of stuff. And whilst it's a subject that evokes really strong emotion for those impacted by suicide, it's actually an incredibly hard thing to sell. And I am in the business of trying to sell at times notions that the ministries want us to roll out. Now, I have to own up to my own issues around some of this, and I think that there's some massive learnings in this. As a leader within the DHB structure, suicide prevention hasn't been my passion. So remembering that I come from a background as a nurse who's worked extensively within mental health, and then moved on to this bureaucracy about 7 years ago, it's not actually something that turned my wheels. And in fact, when the health promotion portfolio was disestablished at Lakes DHB and the suicide prevention project shifted into mental health, I wasn't overly happy about it. And then I started to sit down and talk with people like Patricia and with other whānau who'd been impacted by suicide. And then I started to be humbugged by a particular clinician within our DHB who sent me lots of articles, would ring me up, drop little emails. And one day I managed to actually read one of those whole articles. And it was by Professor Hatamo Ma. I don't know if any of you are familiar with Professor Omar, but he internationally is well known for his fight to stop youth suicide. Now, Hatim talks about the same kids. He talks about those kids who are disengaged from school, are the same kids who go on to develop drug and alcohol issues, are the same kids who go on to be criminals, are the same kids who have massive conduct disorder and or other particular issues, and unfortunately are the same kids who go on to commit suicide. And yet, as a general policy direction, up until a few years ago, we dealt with all of those things in individualised silos. My own experience of this is, and so what I understand about Omar Hatim's kōrero is true. I know that from my own experience. And in an environment, so for Lakes, we have the social sector trial here. We also have a really thriving whānau order initiative, well, we have 2 of them, and we have the children's teams. And in that kind of crowded environment where you've got multiple strategies going on, multiple initiatives, it's really difficult for something like suicide prevention to actually find its voice within all of that. And so Omar Hatim's article for me was like a penny dropping. And I finally bought in. The challenge for me then has been, how do I engage the hearts and minds of an entire DHB? First thing I've done, or looked at doing, was going back to this notion of healthy communities Maori order. Now, why would I do that? I would simply do that because that's actually the vision statement for Lakes DHB. The vision aspires to achieve optimal health outcomes for everyone who lives within the region, and it has a specific emphasis on addressing inequality. Now, that's a really tall order from a DHB with a high needs population and a policy framework that's largely based on universalism. I've pinched the next bit from Tū Whare Toa, but the Whānau Order initiative in Tū Whare Toa, they articulate their aspirations for iwi hapu and whānau around 5 domains, namely cultural, political, social, economic and environmental. Now, if indeed these domains should be the focus of activity, and I believe they are, to develop healthy communities, so the vision of the DHB, how then might we measure the population's well-being? What is the measure we use? Well, suicide is one of them, of course. So the New Zealand Census uses a couple of social indicators. They use housing, paid employment, social connectedness. You'll remember filling those things out in your census forms. But it also measures rates of suicide and specifically measures those as an indicator of social and emotional well-being. So for Lakes DHB, where the national average for suicide is 11.3, that was in 2011, so the national average was 11.3 per 100,000 people, our average was 15.8. So that gives us a bit of a clue that actually here within Lakes we're not doing so well. Alignment, though, of those vision statements, of those goals, of those aspirations, has given us some common ground on which our information can now be shared with multiple parties, and also used in a way that supports planning and implementation. Suddenly, the mission to develop a suicide prevention and post-vention action plan looks a little more doable. Why is that? Because suicide prevention suddenly becomes everybody's business, not just the business of the DHB. The Better Public Services imperative has at its core a focus on collective impact. And I don't know what people understand here about better public services, but really quickly, what the ministries have decided to do is that a whole bunch of our policy documents now go to caucus and are signed off by the whole caucus. So while suicide prevention might be seen as something that sits with health, the Ministry of Social Development, the Ministry of Corrections, and all those other ministries have also signed off against that. So collectively, at a really high level, we've taken shared responsibility for getting good outcomes. So each government agency doing its part to achieve support for families, whānau, hapu, iwi, and communities. Each government department supporting families, whānau, hapu, and iwi after suicide. Each department improving services and support for people at high risk of suicide, using social media to prevent suicide, and then strengthening the infrastructure for suicide prevention. And of course, the wakahaurua and some of the other initiatives that have been raised this morning are evidence of those things. But it is everyone's business. And taking into account then, well, if this thing called suicide prevention is actually everybody's business, I'm the health person sitting in amongst that mix. What's the lens that I might cast over that? A health lens leads me to think about health promotion, building resiliency, and actually when you backtrack it, suicide prevention means addressing the cause. And what do we know about that? Well, again, from a health perspective, what we know is that healthy pregnancies, positive childhood experiences, rangatahi and taiohi that are socially adaptive, and adults who can empathise, care for and nurture others, takes us a long way towards building resilient communities. So just to expand on those just a little bit, healthy pregnancy for health means having women or mama who are smoke-free, having mama who are living in home environments that are family violence-free, they're eating well, they're enjoying the company of other mama or potential mama, they have good dental care. Those are the things that we think about. Positive childhood experiences, and I'll talk a little bit about attachment, but this is where our children actually learn right from preconception. So preconception, they learn about their value and their place as being the most important thing in the lives of their primary caregivers. And the primary caregivers spend all of their time devoted to growing the emotional and social aspects of that child. Rangatahi and taiohi, being socially adaptive, means do they actually know how to relationally interact with other people? And I think on the couch panel this morning, we heard about how, they spend all their time on the social media and they're texting you to say, can I have some bread, please? And can you pass me the butter? We want kids who can actually talk to you as their adult, as their interested other, and share with you their issues and problems. And then, of course, we want adults who can actually care for all of those children, those mokopuna, those taiohi, care and nurture others. If these things exist, the risk of suicide markedly reduces. So, DHBs, what's our contribution then? we've got a unique opportunity, I think, to contribute and inform suicide prevention. Now, Lakes DHB has completed some work of late that I think forms a really good platform from which we can build. And these are the things we've done, and I'm going to talk to these in just a wee bit. But we have, as all DHBs across the country have, we've developed our draft suicide prevention plan. We've put in place a youth health strategy. We've looked at the school-based services, so we've had a bit of a review around that. And those first three things are all being driven at the moment by ministry as direct things that we must do. The one thing that we've done off our own bat is the last thing, a project called Falling in Love with You, Baby. So let's start there, because I think that this is the thing that rocks my world, gets my wheels spinning, makes me really want to work hard around this area. Now, Falling in Love with You, Baby is a project that fell out of the Lakes DHB involvement as a pilot site for the children's team. And if you're unfamiliar with children's team, that's the initiative that seeks to engage vulnerable children in getting better coordination around the care and services that they require, not just for them, of course, but for their whānau as well. And as I said, we were a pilot site, so it's been a bit of an interesting journey. One of the things that really struck us as we were working with this concept and this notion and who these families were was that almost, we never put a statistic on it, but 99.9% of these kids had some issue around their attachment. And interestingly enough, 99.9% of the parents or caregivers that we were working with in terms of those children also had their own issues around attachment. And so we decided it was probably really good value to invest a bit of time and energy in understanding a bit more about attachment-informed approaches to not just healthcare, but to other forms of working with and managing services for these families. I can hear some of you saying, what's attachment? Has anyone done the Nathan McKidy Wallace workshops? Yep, a couple. I'll try and do justice to Nathan. The easiest way that I can describe attachment is this. As adults, we're mostly familiar with the concept of bonding, yeah? So this is where you have your baby's in your arms, you're looking lovingly into their eyes, you're flooded with oxytocin, by the way, which is the love drug and makes us fall in love with them. But that relationship from an adult perspective makes us fall in love with that child, and we bond to them. And we bond in such a way, it's an amazing survival strategy, really. It's more advanced than most other animals in the kingdom. But that bonding process means that as adults, we'll do almost anything to protect that pepe, yeah? That's bonding. That's what bonding is. Attachment isn't about the adult per se. The adult's actually about what the child experiences, the pepe experiences. And through that experience, a baby's brain, which is totally geared up for this, gets its first learnings and understandings about the world. This is the period of time in which we, as human beings, learn about and imprint on ourselves the way in which we will relate to all other human beings from that point on. So at the age of 0, we're learning about the kind of adult we're going to be in terms of our relationships with other people. And that's what attachment is. The thing about attachment is, and this is an evidence-based thing, is that it's common across every human being. It goes across cultures, and so it applies no matter where you live, in what continent or what language you speak. And so we decided that that was really a good point to start, an evidence-based approach that says how can cross-sectoral agencies who struggle to even agree about what is risk, what is an assessment, how is it that we could develop a common language around attachment to actually inform the way in which we work with families? And what we know is that through good attachment, we can have improved life outcomes, Our particular framework talks about children being school ready, talks about young adults being life ready, and then talks about being parenting ready. As I say, we're now using this as a tool to actually influence cross-sector leadership and policy. So this is our opportunity, we think, to put the evidence in front of other funders, other agencies to say, have you thought about doing this a different way? And most importantly, and what I've consistently heard this morning through most of the presentations, is that through attachment-informed approaches, that we develop interventions that promote empathy, aroha. If we don't have empathy, we have very little. We don't spend time listening to people. I heard from the couch panel this morning that the tote te kōrero, where is it? Empathy is that missing component. And even Shona raised it in her kōrero around the children's art. So empathy and personalisation was needed in order for our children to truly flourish. So for us, we think that this is pretty groundbreaking. We think that this is going to be something that will propel us forward in terms of our conversations, both with ministry and ministries, and certainly will bring us potentially the best outcomes for our population group. Aroha mai for that slide. I had some other IT difficulties which meant the original presentation isn't here, but our youth health strategy, or our Taiohi health and wellbeing plan, has been developed. Now this piece of work, again, we love this piece of work, and we did this in conjunction with the Ministry for Youth Development. DHBs actually know very little about youth, believe it or not. Very little. We're incredibly adult orientated, and so we tend to miss the boat around rangatahi taiohi. So we asked the Ministry for Youth Development to pull this together for us, and what young people told them was, well, kind of state the obvious, we want services that are effective for us, we want services that are accessible for us. What was really interesting about that was effectiveness for taiohi. What they recognised was inequality. They said to us quite clearly, we know that our brother down the road, he doesn't even come to school with a sandwich. He should get first dibs at the service, but he's the one that's got no car to take him to the doctor. So Taiohi told us that to be effective, we need to think about ways to address that. And the crunch for a DHB, of course, around that is that transport, no lunch, tend to be social issues, not health issues, and we tend to push them somewhere else. So by having a constructive framework that says to us, actually, everything is everyone's business, we have to step up to the plate and think again about how we might address these concerns. Their other point of pain, if you like, was around transition. So when you get to 15, I think it's 15 in paediatric services, you have to be moved on to adult services. Adult services don't manage young people particularly well, or children. If you're in a mental health service and you need to move on to an adult service, you have to do that once you hit 19. So what young people said was, well, we know we need to transition, but actually you make it really rough for us, and can you do that differently? In terms of access, which was the most fascinating part of the feedback from young people, was they said, we want to be able to see a doctor, we want to have good health services, but we actually don't want kanohi ki te kanohi necessarily. We actually don't want that. We want you to figure out ways to use the technology to do that for us. Where's the app that we can download where I can type in some words and get the right website to come up and tell me the information I need? Where's the program that lets me, from my little home 2.5 hours away from the main hub, where I can go down to the, auntie's place, who's our community carer, go to her house and Skype the doctor up here in Rotorua and have you do my consult that way? And they had a whole range of other ideas. The other thing they were quite critical about in terms of DHBs is that we don't involve them in the development of our health policies. So we write a whole bunch of things about them, we plan service for them, but we never at any point actually involve them. The 4 areas that our taiwohi told us that they wanted us to focus on were alcohol and other drugs, improving mental wellbeing, and by that they meant quite broadly mental wellbeing, so resiliency building and all of those things. Obesity, so there was a really, we talk a lot about how health illiterate our population is, but actually these young people know perfectly well that being overweight has long-term or lifelong consequences for them. They understood that. And of course, being the age they are, sexual wellbeing was right there too. Nationally, there's some work going on around school-based health services. When we start to talk about suicide prevention, one of the things that we're really orientated around is how do we get in much earlier? So, of course, we have to think about, well, where are the kids? And for something like 8 hours a day, they're actually in schools. So how can we influence there? So we did a bit of a review here. Most of the school-based health services are based in deciles 1 to 3 high schools. And what those schools told us was that actually you're too late. By the time you come to high school, you're too late. We know the kids who are going to be problematic back in years 7 and 8, and sometimes even earlier. So they want us to reorientate our funding and the way in which we work to a much earlier age range. Locally, what we recognised was that there's some issues around clinical leadership. So schools are quite complex. They're really devolved, and the school does have quite a lot of control around how it operates. And some schools have to fund their own health services, and other schools get funded by health. So it's kind of not always in sync and not always in keeping with what young people need and want. The biggest thing for me, given that our population of Māori, given the fact that actually as a DHB most of our kura kaupapa will not allow us in the door, is that what they most wanted were tikanga-based models for school-based health services, and they wanted real-speaking health practitioners. I think we got one. We've got one nurse who can kōrero te reo Māori and who can go into those schools and deliver those health services proficiently. The last thing we've done is we've developed our suicide prevention plan and post-vention action plan. Because we're small, what we've decided to do is take a very educative role in terms of delivery. We've got a 3-phase approach. The first thing we want to do is just work really hard on working with our communities and workforce to roll out training and education that they need so they feel their capacity is better built to actually deal with suicide and suicidality when it's in front of them. Most importantly, of course, we want to target, which is the tension around DHBs who are universal, we want to target our more rural, small populations who are, difficult to reach. We have to do some work around our post-vention pathways. We have to do some work around options for people who are feeling suicidal. And more importantly, is we're needing to traverse that really difficult area around how do we work collectively with whānau water, social sector trials and the children's team. Maybe just in closing, I would say that our journey has been really interesting. It's really only the beginning of our journey. There are some multiple tensions that exist for DHBs in terms of suicide prevention and that whole notion and strategy. Just to summarise, because I know that sometimes when you're rambling you miss the kind of key points. The issues from my perspective are as follows. DHBs are set up for universalism, not necessarily targeted approaches. For DHBs to be truly effective and to engage with their cross-sectoral partners, we have to be in the business of engaging hearts and minds and not just mindlessly rolling out policy. It's our job as the leader, as DHBs, as the leader of suicide postvention and prevention strategies, to actually join the dots for some of the others. So actually show them how what they do makes a difference around suicide prevention. And that's why we've reframed the whole thing to call it community resilience. That's what we want to build, because people will talk to me about that, they won't talk to me about the other. We need to think about the juggling act in terms of keeping all the balls in the air, and how do we maintain the momentum of multiple projects in a time and space where there's little resource. And finally, getting some agreement and acceptance that DHBs don't just have to be interventionist services. We don't have to be in the business of doing to all the time, that actually sitting back and allowing education and information to take its course, which will in turn allow communities to develop their own solutions, is a pretty okay way forward. Kia ora rā tātou katoa, he mihi nui, he mihi kia koutou. Are you going to sing? Do I sing my own song? I can sing. You need a one, George. Stay there. Oh,